Hello, this is Eileen Thompson, the Program Director here at Medical Home. I want to thank you all for joining us this morning. I'd like to take this time to remind you that myself or Iris will be muting all lines. During this presentation, there will be 3 poll questions and 3 videos. If you have a question during the webinar, feel free to type it in to the Q&A pod. There will be time for questions and answers after our presentation concludes. At this time, if you are on the phone, to unmute your line, hit #6. I will remind folks during that time. I would like to introduce you to our speaker, Dr. Renee Turchi. She has done her undergraduate work at Cornell University and medical school at the Medical College of Pennsylvania. Renee completed residency and chief residency at St. Christopher's Hospital for Children in Philadelphia. Her research and clinical work focuses on children and youth with special health care needs. Renee is a faculty and associate professor at Drexel University School of Public Health and Drexel University College of Medicine. In addition, she is a medical director of the Pennsylvania Medical Home Program and Transition Program, a statewide quality improvement program for pediatric practices across Pennsylvania and funded by the Pennsylvania Department of Health and the Maternal Child Health Bureau. Renee is medical director of special programs at St. Christopher's Hospital for Children in Philadelphia, where she oversees grants and program development and practices. Her research and clinical work around care coordination and children and youth with special health care needs has been presented and published in multiple national forums. So now I'd like to turn the webinar over to Dr. Turchi. Dr. Turchi?
Good morning. Thank you, Eileen. I'm really excited today to be with all of you. Thank you for taking time on your Friday morning to be here with us to talk about quality improvement. Our goal is really to help folks and help our team, and all of you have already been thinking so much about quality improvement in the work that you've been doing with Medical Home. I want to also thank the Department of Health for their support of our program and making these webinars and our team possible. So today we were hoping to really think about, in a learning community, quality improvement as it relates to practice. And we've held this webinar twice this week with the ultimate goal of our team getting all of you and the network across Pennsylvania, as well as the AAP chapter, ready for our big quality improvement boot camp, which we're hosting in November, and I'll talk more about that. As part of today's webinar, you'll hear from me, Renee Turchi, and you'll also hear from Dr. Sue Cressley, who is the former AAP chapter president, as well as many of you know her. She is in private practice out in, I guess it's Bucks County, in Warminster, and her husband is the CEO of Office Practicum. So as you'll hear with some videos that are interspersed between the webinar today, you'll hear from her. I also would like to acknowledge Suzanne Youngins, the former executive director of the PAAP, who was instrumental in helping us plan and execute this quality improvement work. I'd also like to thank the Pennsylvania Chapter Medical Home team, especially Eileen and Iris, who have really worked very hard to get this presentation up and running. So with that, I want to first just start with this word cloud that I'd like to attribute to the MHI Institute of Healthcare Improvement, and I'll talk about who they are in a minute. But when you think about quality improvement, I think that quality improvement really does encompass so many different things. It's an umbrella term that has been used so much in medicine over the years. And I think this word cloud really underscores that it's what we'll talk a little bit more about today, that it encompasses many different things, many different team members, and with the evolution of healthcare, encompasses very different skills and systems approach to really execute quality improvement in a coordinated fashion. So in order to kind of make sense of that word cloud and move things forward, I chose to make this webinar 3 parts. And please, I know that we're over lunch, so I hope that all of you are eating, and we aren't going to necessarily take any breaks. There'll be some videos, but certainly we hope that this is useful. So in these 3 parts of the webinar, we're going to be covering what is quality improvement and give some historical perspective on where it came from, talk a little bit about what's in it for me, and from me really meaning where you sit in your practice regardless of your role, and really spend some time also talking about what's involved in quality improvement. How do you roll up your sleeves, and how can you get this going in your office next Tuesday? So I'm thinking about part one, what is it and where did it come from? I often think anytime we're teaching anything, whether it's clinical care or practice transformation, that understanding the root or the historical piece behind the evolution of a concept really helps us understand it better. So in order to accomplish that, we are going to talk a little bit about the premise behind quality improvement, think a little bit about some of the key players that have quality improvement as their core mission in organizations. Dr. Krustley is going to focus on that piece, and recognizing other organizations that use QI and quality measurement and how it affects you in practice. So I think the good news is, for those of you that are on the phone with us today, you've been engaged with the Medical Home Initiative for many years, some of you are new to our family, but the work that we've been doing together with you in the AAP chapter and the Medical Home Initiative really is all in line with quality improvement. So as you've embarked on this journey, you really got this, and I sort of think about quality improvement even in my own practice as just sort of raising the bar and raising the game of what you do. So that's good news. As many of you know that are involved in the Medical Home Initiative, we have been in existence since about 2001 with variable funding, currently funded by the Pennsylvania Department of Health Title V. And as you know, we're situated and come out of the PAAP chapter, which I think is critical to executing and ensuring that quality improvement happens because of the unique relationships with Medicaid and all that's happening with healthcare. I just came from a meeting talking about what Medicaid is doing around quality improvement with pay for performance literally 15 minutes ago. And I'm constantly reminded of the work that I've had the privilege of doing with all of you in Medical Home. So as you know, as we've been working on Medical Home, and a lot of you have probably seen this slide before, but I kept this in here to remind you that as you're doing Medical Home, and one of the core goals of our team, and as you've worked with, the dream team, Jason and Iris Ann and Angela and Carol and Andrea, you know that as we come out to your practices that one of the first goals is supporting QI and the practice transformation. And as I'll talk a little bit about today, the other key constructs in achieving QI include incorporating family-centered care and the care coordination. Really, you can't do QI without it. And as you think about at the end game, we're going to talk a little bit about the data and how measurement is so important in QI and the financial viability. With, again, the ultimate goal is fostering, ultimately positive and favorable outcomes for our patients. So as you know, the different QI efforts that we have embarked on, and maybe you haven't thought about them as much as QI, but again, I want to highlight that a lot of you have been doing this. So we utilize implementation guides that many of you use in your practices. One of the key things we always talk to you about is first identifying your practice team. And what you'll hear from me today is talking about how a QI team is sort of a little subcommittee of that larger core. You guys schedule regular team meetings, and we're going to talk about having QI meetings. And certainly there's needs assessments, and many of you do your medical home indexes, and a lot of the registry and population management that you have embarked on already with your teams is all part of the QI journey. You use patient huddles, care planning, you're working with your community partners, and again, that care coordination that is so key to all of our practices is really part of the execution. And I'm going to talk a bunch today about how there's the unique and critical role of our parent partners in family-centered care really helps us get QI going. And certainly thinking about the special projects that many of you have been involved in. Some of you have done J-code certification for medical home or NCQA, which we'll talk about in the acronyms in a minute, but looking at a lot of the work you're doing around autism and certainly the work that we're doing around behavioral health. This is all part of the national landscape and the evolving and very exciting medical arena that we find ourselves in. And certainly for all of us, in the end game, we want to do what's best for our patients. But quality improvement and the quality improvement work that we want to talk about today and take to the next level at our boot camp in November really does help us with payment and office and policy changes, but certainly is going to help foster the financial viability for those of us in primary care that are often struggling to survive. So I first want to switch over to an audience poll. So this is kind of like Who Wants to Be a Millionaire, for those of you that are as old as me that used to watch that show. And what I'd like to do is just wanted to get a sense of those of you that are on the phone, ask you a question so you can help. We're just going to be able to see for everyone the answer here. So has your medical home team worked on quality improvement projects initiatives in the past? So if you could answer this for us. Yes, and we have a designated QI member. We talk about it at medical home meetings. Or sometimes if a project comes up, no, we haven't. Is this, just meant to sort of get a poll of who's on and, just gauge where you are in your QI journey. Give everyone a minute. So it's great to see that some folks actually already have QI team members or talking about it, and lots of you are already thinking about different projects and using QI. So that is really that's really great for us to move forward and to just get a sense of where everyone is. So we'll go back to the presentation. Thank you, Iris. So in thinking about that, and thinking about those of you that are anywhere on that journey, that's just meant to take the temperature. It's exciting to me that a lot of you are thinking about this already. So anytime we are in practice, and I know anything that you're rolling out, and I think QI is no different, you want to think about setting a goal for your office. And in doing that, you have to also start with understanding the guidelines of that goal and following best practice. So maybe it's best practice related to your giving vaccines. What are the guidelines? Do the guidelines change? Recently, a lot of us in practice, recently there was something released that about HPV vaccines, that if you started vaccinating children less than 15, you only had to give them 2 vaccinations versus 3 if they're older. So understanding the guidelines and following that best practice is where you go to set this goal. Establishing the habit and continue repetition until it sticks. So that's really part of quality improvement, and you'll hear me talk today about the pedagogy and the approach to quality improvement. Is a lot about measurement, coming back, implementing the change, and recognizing that there's no ceiling. So I've been throwing out this acronym QI from the beginning, and what am I really talking about? What is QI? Well, QI focuses on the attempt to change a specific aspect of a field that has been identified as needing improvement. So, if you use the example of HPV vaccine, and I can, certainly very humbly and honestly say that for my office, every time we have our vaccines for children, our VFC audit, our HPV vaccine rates are always a goal for us. And so we've often identified that as an area needing improvement. And so we've used and thought about QI efforts with our team to do that, although sometimes probably aren't calling it exactly QI, but many of you have done the same thing. So you work to gain insight into the function of that system and change the system. So you're thinking about your processes. So maybe it's identifying, children in advance of a visit to see who needs HPV, or running reports in your EHR to see who has a care gap with a specific vaccine. And you're working on QI, you're focusing on patients or your clients, your teams, and your data. And those are all the key pieces. You're looking at the data that you have, you're thinking about the patients and the best practice care, and you're setting a goal. The premise really is that quality in healthcare really is equivalent to the correlation between improved health services and the desired health outcomes of individuals and populations. For any of us, I think no matter what you're doing, even if you're making lasagna, there's always room for improvement. You can't improve what you don't know, and that's a really key thing you're going to hear Dr. Cressley talk about as well. That's why the data is really, really important. And measurement is key. You really want to have data. It can't be a gut feeling. I know for myself, often when I have a sense of, hey, can you pool the number of kids in our office that are, we look at our EHR, we did this when we were working on transition for children that were over 21 that we needed to transition, and we completely underestimated the number of youth. When you actually see the data, sometimes it really is a great kick in the pants to help you be motivated and want to move things forward. So with that, I wanted to take a minute to just talk a little bit about the story behind QI. And I'm going to focus a little bit on the Institute of Medicine, which is kind of the beacon for those of us in healthcare. We really, from years ago, have learned that, less than half of patients in the U.S. actually receive recommended care. And so in thinking about quality improvement and, thinking about the historical context, one of the things that I wanted to include in here was, to recognize that QI is also applicable to other industries. And I wanted to give you guys an example of something from a really good book, and actually a great author. If you guys have ever heard of Atul Gawande, who is a physician, who writes, there's some really good books that have been out. He has a book called On Being Mortal, and they're really, if you're ever interested in interesting reads that are they're a little nerdy, but not terribly nerdy. But they're interesting because they apply a lot of what we do in healthcare and health policy and public health to real world. And this particular book is a good one. The Checklist Manifesto. I'm a checklist person and how to get things right. But I thought this was a really good example about how QI was used in other industries that he talks about in this book. And it's relevant. So in 1935, the Army Air Corps held a competition for the rights to contract with them for a long-range bomber plane. So Boeing, which many of us have heard about, that was a favorite plane, crashed during the competition due to the pilot error because this new plane was much more complex than a standard plane. So it had all these bells and whistles, but it was really difficult for people to fly, and so it was deemed too much airplane for one man to fly. So as he talks about in his books, at that particular time, the Army engineers had to give the contract to another airline. And they did that, but they didn't want to give up on this plane that they knew had all these bells and whistles and had so many other things that they knew that it could do. So they trialed a few of the Boeing planes, and they actually just implemented a very simple checklist for takeoff. So they took something that was very complex, and they simplified the plane's complexity. And in using a checklist, which is the premise of this particular book talking about the value of checklists, but it strikes me that it's so relevant to QI. In this particular case, by implementing and rolling out that checklist, when following it and tracking it and measuring it, they found that not a single crash occurred over 1.8 million miles flown after that. So then the Army made a large-scale purchase of the plane, and that's the B-17 that many of us know today. So I think this story is relevant to us. I know sometimes, in my own practice, we'll get different reports, or you start thinking about what you want to embark on, or we have, I think for a lot of us, right, we're even thinking about the school year that's upon us with all the vaccines, or sometimes it seems like a very insurmountable or complex task. But, breaking it down and breaking out and chunking it out with QI and taking one piece and sort of implementing things like checklists and can be very helpful. Dr. Kresley in her video is going to talk about the various players in QI, but I wanted to highlight in my piece, so you'll hear about the folks in National Academy of Quality Assurance. I'm going to let her define that in a minute, but I wanted to sort of spend my time before we launch the video in talking about the Institute of Medicine and the role. In March 2001, the Institute of Medicine came out with a report called Crossing the Quality Chasm, the New Health System for the 21st Century. And this Quality Chasm Gap report really defined the quality chasm, which I think really helped us promulgate us into quality improvement. And they really talk in the Institute of Medicine report about the difference between what is scientifically sound and what's possible and the actual practice and delivery of health services. I'm sure a lot of us have been in that position, right? Like I'll sometimes sit in meetings and I have very well-meaning folks who maybe aren't on the clinical ground in my office in my health system, and they'll say something about what they want my staff to accomplish, and I just know I'm sitting there thinking there's no way that this can possibly happen. So sometimes there's these goals that are set up, but sometimes as you think about someone who's boots on the ground, you know that just given the staff that you have or the manpower or just given what can happen in patient care, you might know that certain things can happen. But so there is that sort of like the goal and then the actual practice. But then how do we come meet somewhere in the middle? You're not going to throw your hands up and say, okay, we're never going to get to 95% HPV vaccine rate, which was what we were facing in my office. But I knew that we could probably get somewhere like 70%. So really thinking about that gap and really thinking about, the need for healthcare quality improvement and to really start closing a gap or closing the chasm as they describe in this report, you really need to start thinking about what's possible and what happens in the actual practice. I thought it was relevant for this talk to talk about the quality aims that are outlined in the Institute of Medicine because I think they're relevant to what we all do and relevant to quality improvement approaches. So when you think about SAFE, what the Institute of Medicine describes in the quality aims is that, and all of us, I think these all probably all of our quality aims in our practice, but being safe is avoiding injury to patients from the care that's intended to help them. So we certainly want to be providing safe care. We want to be providing effective care, so we don't want to overuse ineffective care or underuse effective care. So, you certainly don't want to be underusing vaccines, but you certainly don't want to be overusing, let's say asthma teaching or something that is not going to be, taking a nurse to do asthma teaching more than it's deemed to be effective in your office is not going to help you either. You also want to be patient. In the IOM report, they talk about patient, but we know in pediatrics we say patient and family-centered care. So I think that it's critical, and we promote that all the time. We want to provide care that's respectful and responsive to individual patients' and families' preferences, needs, and their values. So as we always say, that should be, when you think about developing a care plan, that's why those goals should be set. You should never be developing a care plan without the input of a family member. And we always want to think about cultural values and race and ethnicity and language preferences and health literacy. Quality should be timely. You want to reduce wait time. Don't just mean wait time in the waiting room. We want to have access so that patients can get into our offices for 6 visits and reduce them going to non-medical homes like minute clinics or the emergency department when it's not necessary. We want to have harmful delays for those who receive care and those who give care. So thinking about things like, transitions of care from hospital discharge and getting folks in to reduce readmissions. We want things to be efficient, so we want to avoid waste, and that includes waste of supplies, waste of equipment, thinking about ideas. So you don't want to spend all your time coming up with a way to address a particular project or take team time away maybe when it's not something that's going to happen. So we want things to be effective as well. We want to provide care that does not vary in quality, so it shouldn't matter what insurance someone has, whether they have Medicaid or private insurance or dually insured. It shouldn't matter their gender, their sexual orientation, their race, ethnicity. You should be providing the same care here where I'm sitting in Philadelphia as folks are getting in Potter County. It shouldn't matter. And families' socioeconomic status should be immaterial for what the care they can access. They should be able to go to the best surgeon or the best specialist that they need to get their care. And that's really what the IOM seeks to accomplish. I wanted you to have these slides in your slide deck, but in the video we're going to show in a couple of minutes, Dr. Cressley is going to talk about the players. So she's going to talk about the Institute for Healthcare Improvement. You'll hear their name in my talk today because they are the leaders in quality healthcare. They have amazing conferences. They just are pretty expensive to attend, but if you have the ability to get to one, I highly recommend it. And she's also going to talk a little bit about the Agency for Healthcare Research and Quality, as well as HRSA, the Health Research Services Administration. And with that, I just want to highlight that in your, you should see some shared documents. We have some handouts that our team put together for you, and one of them actually includes the HRSA toolbox for quality improvement and resources. We wanted all of you to have some tangible tools that you could be thinking about and using in preparation for the big boot camp conference coming up in November. So I encourage you to take a look at that HRSA quality improvement toolbox that's in there. It has lots of tools. There's actually a clinical performance measures toolkit, and there's some articles in there. There's some patient safety, so encourage you to check that out. I'll highlight some of the other handouts that we have as well in that shared documents that you all can access. Dr. Cressley is also going to talk about meaningful use in the video and how that is so critical for those of us that have been engaging in meaningful use and how it relates to quality improvement and the work that you're all doing. Again, I wanted you to have that slide. So I wanted to shift the last part before we segue into the video with Dr. Cressley about pay for performance. And you'll find that in the talk today, one of the things that I tried to do here was actually take a minute and define some of the things that a lot of us throw out all the time. I find especially medicine is like riddled with acronyms, and I sometimes think how challenging it is for me, and I can only imagine how hard it is for a family member. I think that we use the term pay for performance and even HEDIS measures. I mean, people say this all the time, but I chose purposely to put some slides in here to kind of take a minute for us to understand what pay for performance is and where it comes from, so we're all talking about and understanding the same thing. So in that same Institute of Medicine report that I referred to, the Crossing the Quality Chasm, they recommended that the federal government identify and test different payment options that aligned with compensation goals and quality improvement goals. And so those of us that have been in medicine since then know and have seen the evolution of that. And sort of the thinking back then was that, fee-for-service, which is where a lot of the healthcare system was at that time, the thought was that it encouraged overuse, so that people and practices would just have people coming in all the time, and that capitated payments encouraged underuse. So the idea was that, practices might and families might not be coming in as much as they should with just that monthly payment. And the sort of genesis of pay for performance at that time thought that it created the right incentives so that you were actually rewarded for what you did, and that there was data that showed that you actually accomplished that. And so really the pay for performance piece is, sort of started in the evolution was as part of an overall quality and cost management strategy. And so with that, the phrase itself describes initiatives that are really aimed at improving the quality, efficiency, and value of healthcare. So it's really meant to provide financial incentives to those of us that are in practice. Pay for performance also happens at the hospital system level. So, at the hospital system, it might be for patient safety or for admissions rates. Now there's a lot of looking at cost-shared savings and value-based healthcare, so that while hospitals used to be incentivized, I should say, I don't know incentivized, but they were, I guess, more rewarded for hospital admissions. Now, the change of healthcare is trying to get admissions down but how are you not going to bankrupt the hospital who sort of relied on admissions as their source of revenue? So the idea of these stage sharings is that, a payer, for example, might reward a hospital who decreases their admissions with some shared savings so that they're not breaking the bank by not having to be able to bill for those admissions that are down. So, but the ultimate goal, and I think we all have to remember, and I say this all the time in my own practice, I'll never fault anyone if their ultimate goal, if they do something that might be quote-unquote out of the rules, but if their ultimate goal and they're doing it in the name of quality or in the name of a child or to help their family, and you always keep them and the patient and your family and at the center of what your goals are in any interaction, I don't think you can go wrong. Sometimes things don't always end the way we want them to, but I think if you keep that as your beacon, the outcomes always end favorably. So the pay for performance did get addressed in the ACA and healthcare reform. And it certainly is addressed in Medicare, even for adult colleagues, and there's a lot being talked about with accountable care organizations that is beyond the scope of the talk today. But as I talked about with hospital-based purchasing and physician quality reporting and bonus plans. So P4P, they started saying fee-for-service has not succeeded, and really I'm going to talk about the triple aim later, but this idea was that the pay for performance, getting paid for what you do well, will incentivize that triple aim, the triple aim being lowering the cost of healthcare globally, but providing quality healthcare for individuals and populations. So the truth is, many of you who are in federal qualified health centers or community health centers, you're already doing a lot of this work, and in some ways some of those health systems are ahead of the curve in quality improvement. Because in order to maintain that status, they have quality assurance programs, and their reporting is very much nestled in quality improvement. And so as a result of that, the Centers for Medicare and Medicaid stated that, way back when, that by 2016, 85% of fee-for-service payments would be linked to quality, and by 2018, which is upon us, 90% of fee-for-service payments will be linked to quality. So that's where we find ourselves now, and that's why this is so critical that all of you are engaging and thinking about this for the financial viability of your practices. And as a result of the pushing through this pay for performance mantra or movement, in 2012, we could see that almost no payments were made through these alternative payment models, and now look where we are now. So I wanted you to have also in your slides what are the forms of payment for pay for performance. So there's bonuses, and it depends sort of on the relationship with your payer and how their pay for performance is set up, but some folks get bonuses which are based on meeting minimum targets. Some have withholds, so it might be that you have like a base that you get for payment, but then until the end of the year or until your quality report card, then you get that extra bonus payment, and so you have a withhold based on, and you're reimbursed based on a meeting a minimum target of care pay for performance. There's quality grants, so some insurers provide funding for quality improvement projects. Maybe it's your PCMH recognition. Sometimes that'd be community health workers that some of us have. Some pay for performance gives different reimbursement for chronic care management or point-of-care clinical information systems. So it might be, some plans are focused on asthma as a cost driver, so they might give you payment for care plans or for patients getting their controller meds and things like that. And then, as I said, accountable care organizations, there's a shared savings that now many of the larger systems are starting to embark on. So how does pay for performance affect you? Well, pay for performance, hopefully many of you are already in this arena. You're getting maybe direct incentive payments for improved quality. If any of you have seen your quality report cards, you're usually benchmarked against your peers in your catchment area. And again, you might be getting those bonus payments. You might, some of us get higher per member per month payments through the following year. You might be able to negotiate higher fee schedules based on the payments that are the patients that you've favorably impacted. And Dr. Kessler will talk about this in a minute, but there are some payers, and I know there's one out here in southeastern Pennsylvania, who are creating preferential networks that are excluding poor performers. So what I mean by that is that it could be that, someone, let's say Dr. Jones's practice has a quality score for a particular payer that's, 90 at the 90th percentile, and Dr. Tree's practice is at the 50th percentile for quality scores. but me and my family wanted to go see Dr. Tree. Well, my copay at Dr. Tree's practice might be $40 because their quality scores are lower, whereas my copay if I went to Dr. Jones might be $10. So some of the payers are talking about ways to have patients preferentially work with or select providers by adjusting copays based on quality scores. So again, this is all the more reason that I want to get you guys thinking about this, and our team in the state really wants to continue to have these quality improvement boot camps so that medical homes are poised in a good way as these things come down the pike. So I'm going to talk a little bit more about this, the quality measures versus quality improvement. I have a slide sort of at the end of this webinar that really, I think, hones in and hopefully summarizes a lot of what I'm going to talk about. But, you know, the metrics are key. So the metrics are, you know, getting what you have. It's a measurement. It's pulling the data from your charts or your practice. But quality improvement, is really that big systems level mindset. It's the approach. And it requires, you know, a real commitment to the process. You know, I sort of think about it as like you're training for a marathon, and so, you know, the times that you go to just lift weights at the gym are just a small part of the whole training for the marathon. Training for the marathon, you know, takes a whole mindset. It takes months. It takes years even to train, and you know, just doing one aspect of your workout is only one small part. So it's important to think about that, but you need to, excuse me, also think about where the measurements came from and what we're measuring and why they're important. So we'll talk a little bit more about HEDIS and some of those measures, but the measures that are selected they're not typically random. They usually start with the evidence base. So, you know, they start with the fact that, you know, getting dental care has actually been shown to reduce caries, and that not having good oral health, for example, is detrimental to children's health care, overall health. So they start with an evidence base, so based on clinical guidelines. If there aren't clinical guidelines, there's often, you know, there's a consensus group that then meets to determine those. So we think about things like postpartum depression, you know, and that we screen at 1, 2, and 4 months. That didn't come out of the air. There's an evidence base about when moms are more likely to become depressed, and that's why the screens are at that time. So those guidelines and the measures are often developed by government agencies, nonprofits, and sometimes even for-profits. And then they come out, and then different payers and practices or systems may adapt them or adopt them. So many of you know that right now, to use the postpartum depression example as an example, I know out here in Philadelphia, of all the different Medicaids, there's only one right now that's paying us for postpartum depression screening. There's, you know, many of them might get mandated by the state in Medicaid, but even though screening for postpartum depression is part of Bright Futures guidelines, so it's an evidence-based practice, not all the payers adopt that at the same time. But it doesn't mean we're not going to do it, but how many things can we continue to do if we're not getting paid? So that's kind of why it's important that all of us are involved in some of these discussions. So at this time, I wanted to just throw out some questions to folks, and we'll pause for I throw out these questions at the end of each part if anyone wants to talk now, or we can, you know, we have Q&A at the end, but just kind of pause here before we launch Dr. Cressley's video and just think about, are there any players in the quality space that we didn't mention? Thinking about your quality improvement report cards, you know, thinking about, do you have meetings with your payers? Would you like to have those? We certainly do in my practice. I think they're really helpful. You know, you get the report cards, and so it's really helpful because it's someone else's data. I think it's really helpful to sit down and know where they came from. Do you have a QI team? And if you do, who are they? What is their role? Give some thought to who you think you need and what their role would be. If you have a QI team or medical home team, do you review? You know, when could you do this? Could it be part of another medical home meeting? Could it be tagged on to 15 minutes of a staff meeting? Do you think that maybe once you get the quality report, you know, maybe the tickler is when you get something from a payer, make that the impetus to sit down and do it? Is your practice potentially at risk due to suboptimal quality performance? So if you're in that network, could you potentially lose patients to surrounding practices in your area that might have higher performing practice quality scores? Think about NCQA certification. I don't know how many of you are planning to renew. It seems like the sort of shift in Pennsylvania has occurred over the last probably 7 or 8 years. Less and less payers are recognizing NCQA. So we're seeing that some practices are making the decision not to go on to get certified because it is costly. Some folks do other certifications like URAC or JCO. So these are just some things to begin to think about. I'm happy to have anyone talk if they have a question. Any comments there?
Did you want me to put the video on now and then address?
Sure.
Okay.
Hello and welcome. My name is Sue Cressley, and I'm a practicing pediatrician in Warrington, PA, and the immediate past president of the Pennsylvania chapter of the AAP. In addition, I serve on several national AAP councils, committees, and sections, including the Council on Quality Improvement and Patient Safety, the Section on Administration and Practice Management, the Council on Clinical Information Technology, and others. It's my pleasure to speak with you today. Welcome to this 3-part series on quality improvement presented on behalf of the PA chapter of the American Academy of Pediatrics and the Pennsylvania Medical Home Initiative. The PA Medical Home Initiative is a project of the PA Department of Health in partnership with the Pennsylvania chapter of the American Academy of Pediatrics. This is meant to be an introduction and provide you with background information so you can effectively embark on quality improvement in your practice. Part 1 in our series will look at quality improvement, what that really means, and where it started. Our learning objectives for this first segment are to understand the premise behind quality improvement, identify the key players that have QI as a core mission, and recognize other organizations that use QI and quality measurement. As physicians, practice managers, clinical and support staff, and other team members, we are all dedicated to improving the health of our patients. Quality in healthcare really is the link between improving what we do and how it improves the health outcomes of our patients that we see and the whole population that we serve. Our work is never done. We know there's always room for improvement, and even when we're rock stars, it takes work to remain at the peak of our game. The underlying premise of this work is that we can't improve what we don't know about, and we need to have some way of measuring both our baseline performance and whether the changes we make have true improvements in outcomes. This is just one of the studies that have demonstrated that we have significant gaps in what the evidence shows is good care and what our patients actually receive. Research studies and reports from the Institute of Medicine provide focus and urgency to our work of improving quality and safety for our patients. So who are the players in the quality space? Most of you have heard about NCQA, the National Center for Quality Assurance, but not everyone knows who they are or what they do. NCQA is a private, nonprofit organization that's been around for over 25 years. Their mission statement reports that they are dedicated to improving healthcare quality. They do this through a variety of programs for many different stakeholders, from insurance payer plans to practices like ours. Insurance companies report HEDIS metrics to NCQA, so the public can compare performance when choosing a plan, and payers can compare their performance to others and work to improve. You may or may not have heard of the Institute for Healthcare Improvement, or IHI. This is an independent nonprofit organization founded around the same time as NCQA, but has an international focus and really looks at how we can collaborate, work together across different healthcare systems to accelerate improvement and healthcare reform. The government has a big stake in quality. If you think about it, government, that's really our tax dollars, fund Medicare and Medicaid, which covers more than 1/3 of all Americans. The Agency for Healthcare Research and Quality, or AHRQ, is the lead federal agency charged with improving the safety and quality of America's healthcare. HRSA, the Health Resources and Services Administration, is part of the Health and Human Services, or HHS. It's the primary federal agency for improving healthcare to our most vulnerable people. So where else is QI used? It may be easier to speak about the places in healthcare that are not involved in QI at this point. Clearly part of the entire healthcare IT movement through the Affordable Care Act that led to Meaningful Use program is founded on the premise of improving healthcare. As we move toward pay for value in MIPS and alternative payment models, Medicare is all about paying for quality. In the meantime, many of our private payers use pay-for-performance programs to drive quality improvement. Practice transformation around the medical home model, whether or not you choose to be recognized by the Joint Commission or NCQA, has measuring and improving quality at its core. Board Maintenance of Certification, or MOC, has an entire section developed to fostering, measuring, and evaluating quality in its Part 4 Improvement in Practice program. The Meaningful Use, or MU program, was designed to promote adoption of and improvement in use of electronic health records. All of this was done to improve quality, safety, and efficiency, as well as to reduce healthcare disparities, and ultimately was designed to move toward better clinical and population health outcomes. One could argue what the true costs and outcomes have been to the MU program and whether the return on investment has been demonstrated. But it's clear we are not going back to paper, and the move to improve quality using data is here to stay. Many practices across the state have at least one payer that offers a pay-for-performance program. High-quality performers can be rewarded in a variety of ways, but almost always result in real additional monies to the practice. This may come in the form of bonus payments. For my practice, our major payer will be rewarding us for our high-quality work with a bonus payment that covers more than one nurse's salary and benefits for the year. In addition, we got additional monies throughout the year as part of our monthly capitation checks. Some payers are intentionally narrowing their networks and terminating practices with low-quality performance. We haven't seen that as much in PA as in other parts of the country. But if your quality is not as good as your peers and there is network adequacy in your region, your patients may be forced to leave you for a higher performing practice. In some areas of Pennsylvania, there are payers who are giving patients lower copays to go to high performing practices. I've seen patients transfer to my practice because their out-of-pocket expenses are lower in our high performing practice. We will talk more about how to measure quality and collect data in the form of quality metrics. But to actually improve your quality takes more than collecting numerators and denominators. It takes a mindset of your entire practice, from leadership to every team member. There must be a mindset of, how could we be doing this better, from all dimensions of your practice. Quality improvement also requires commitment to the process. That means time to do the hard work involved and an understanding of why this matters. So where do those quality measures we alluded to in the previous slide come from? In general, they start from evidence-based research and are based on clinical practice guidelines. In most cases, there's a stakeholder group convened to build consensus. Those stakeholders almost always include practicing physicians, and many of the pediatric guidelines have included AAP members just like you. I've been asked to provide input into various quality measures over the past few years. The outcome does not always reflect my best guidance, but there is general consensus achieved by the stakeholders around the table. Quality measures can be developed by government agencies, private nonprofits, for-profits, and others. Some of our biggest struggles as pediatricians is that these measures are often adapted in some way by payers or health systems, and it seems like everyone wants their own customization of a national quality measure. While there is work being done at the AAP and in other organizations to harmonize and agree upon definitions of measures for children, this is ongoing work and will continue to require our willingness to be part of the process and not just complain about the outcome. In addition, sometimes the measures get used outside their original intent and have unintended consequences. For example, the chlamydia screening in women was originally intended to begin to measure the burden of chlamydia on at-risk adolescents in the Medicaid population. Unfortunately, there's no good way from claims data to define an at-risk woman, and suboptimal surrogates on birth control having had a pregnancy test were used. Additionally, in the Medicaid population, there is no risk of disclosure for parents getting an EOB. As this was widened to private payers, it began to have wider implications. So hopefully by now you're getting the picture that if you're not already involved in or getting geared up for quality improvement in your practice, you're at risk to have the healthcare system pass you by as you stand at the curb and watch the bus drive away. This concludes the first in the three-part series on quality improvement. We hope you have a good understanding of the forces behind quality improvement and recognize the organizations which develop, measure, report, and promote quality measurement and quality improvement. We encourage you to contemplate and discuss further as time allows.
Great, thank you, Iris. So we're going to move on to the second part of our presentation, what's in it for me. And the learning objectives of that section really we're about to embark on is really identify the reasons to become involved in QI and understand better the return on investment for quality improvement participation in your practice, and begin to envision what QI can bring to your practice if you participate fully and get engaged. So why is it important? As we talked a little bit earlier, quality improvement is going to affect the safety, quality, and efficiency of care at your practice. And in doing so, it's going to improve your patient and family-centered care delivery, as well as favorably impact the family satisfaction. And we're going to talk a little bit about cleaning satisfaction in your practice. Also, quality improvement really will foster you working collaboratively with quality and safety officers. If you have those folks, if you're part of a system, as I mentioned earlier, you can work collaboratively with your payers. So, sitting down, getting the quality improvement report cards, maybe they can do one-on-one visits. And I think it's really important anytime they come out to have the set visits and talk about them with your practice. Also, your practice team and other health system leaders, thinking about who else is in your team and thinking about the regulatory requirements that are coming down. Also, I think quality improvement sometimes really helps us learn and practice the evidence-based guidelines. Sometimes, usually at the National AAP meeting, there's always a section on Bright Futures where they launch the guidelines, but it's often sometimes when they talk about those meetings and the new Bright Futures guidelines, it takes, several years. So people talk about how an article can come out and it can take 5 to 7 years for it to be implemented into practice. So the nice thing when these quality improvement guidelines come out is that, you can be on the forefront of starting to apply fluoride varnish in your office, or screening for postpartum depression, or getting a lead screening at the time it's supposed to, by engaging in these quality improvement practices. And then ultimately you're improving your scores and then getting your bonus payments. Also, you can share your results. So I know with us, we just had a call with our colleagues at CHOP at my practice here, and we were talking about some of the work that we are each doing with community health workers. And I think sometimes it's really helpful to be talking to other people in your networks or in your neighborhood about how they're rolling things out. And so I think sharing, that's the beauty of our network here with Medical Home, is that we share ideas, we share our successes and our challenges so that people can learn from them and move forward. Maybe you're going to publish or present your results to help others, and Dr. Cressley is going to talk about maintenance of certification Part 4 and how quality improvement can help you meet those guidelines. So when we think about improved care, you can't measure what you don't measure. You can't improve what you don't measure. So you really can't make a difference if you don't know what it is that you're trying to improve. I could say that, hey, I know that our HPV vaccine rate is probably not where it should be. Let's just do something. But how can I really improve if I don't know what the baseline is and where to go, what my delta is going to be? And, really you want to think about, as I say, focus on the patient. So you're going to be providing them care that's evidence-based, safe care. You want to have support for family and patient engagement. And you want to coordinate your care with other parts of the larger system, whether it's in a larger hospital system or the system outside of your office that you refer kids to, the community partners, the engagement, the behavioral health educational system. And so also thinking about improving patient care, you're addressing cultural competence. You're looking at not just the literacy of your patients and how they read, but their health literacy, really thinking about our communication and making it ultimately as patient and family-centered as it can be, as well as linguistically appropriate. So all of those things can be accomplished by better QI. And in your work with us in Medical Home, we really feel like you've been doing a lot of this. You've laid the groundwork for a lot of this. You've got parent partners that we work with, our parent advisors here in Medical Home. Many of you have been engaged in resource nights or inviting your families to staff meetings. Our Andrea, Iris Ann, and Angela have maybe helped you with some focus groups, and hopefully you've gotten to meet them or work with them, and if you haven't, I highly recommend that you do. We've also been working with many of you on getting feedback. So many of you have had your families get family surveys done, and we're about to be sending out those practice reports in the next month. That is the aggregate of your family surveys. Many of you, if you don't know, most of the payers you participate with are doing surveys of your patients. There also are suggestion boxes some folks have in their office. And sometimes people hire third-party payers to conduct surveys, whether it's to get certification maybe it's Prestini, there's NRC, there's lots of different groups that for a small fee they'll do it, but you can often do some of this satisfaction feedback with us as part of Medical Home, or you know, on your own with some of the work and support that we provide you. So just to highlight the focus group questions, these are some of the things that our family advisors, you know, just have done, you know, sometimes getting someone outside to sit down and get families to talk a little bit about their experience with their child, what's been helpful, any unmet needs, and really thinking about any recommendations that they might have for medical practices or families. So in doing that, sometimes I think we help families get talking. So I wanted to go to an audience poll at this time. We're going to just want to get a sense before I launch in on quality improvement report cards. So before I start talking about that, I wanted to get a sense of how often do you review your quality improvement report cards from your payers. So if you guys could actively, for those of you who can, answer the question, whether you do it regularly, sometimes not. Maybe it'll become a goal of yours after this webinar, but we'd love to have you participate. Give everyone a minute to do that. Okay, so it looks like we've got some responses here. I'm impressed to see that many of you actually do regularly review your report cards. So that's awesome. We can end the poll. And in thinking about that, these quality report cards that come from your payers, a couple comments that I would have on that is, we can go back to the slide presentation, Iris. That would be great. Thank you. And you know, the report cards are data, so you're getting those improved payments based on those report cards that you get from the payers. And you know, and thinking about where that payment comes from, you know, it's the evidence-based services that adds additional revenue to your bottom line. So you get these bonus payments, and it's important to recognize that at the insurance level, they have, you know, to be answering to Centers for Medicare and Medicaid, or in our case, you know, to Harrisburg with Dr. Kelly and his group, who ultimately answers to the federal government. So, you know, as they incentivize us to, you know, have improved HEDIS measures, which we'll talk about in a minute, you know, we're helping them because they have to report data out to their higher-ups at the state and federal level. So it behooves the payers to want our scores to be as high as they can because it helps them ultimately in their plans. And so that's why it really does give you negotiating power if you are a practice that has higher scores, because a payer is going to want you in their network if your quality scores are higher, because you are making them look better, and they want to learn from you to help share the improvement to their other clients. So the payers have to report HEDIS measures, and they need us, the practices, to do the work to get the improved scores. Often HEDIS measures are selected because there are things we need to improve upon. You know, it's very rare that someone will have a new HEDIS measure and that they're hitting it 100% of the time. So with that, I thought it was important for this talk to take a minute, because I didn't even know how many people knew. I often have to think in my head for a second, what does HEDIS stand for? It's a term that we throw out all the time, but HEDIS stands for Healthcare Effectiveness Data and Information Set. So I want everyone to know the acronym and have it. And one of the things, another additional handout that you all have in your toolbox that Iris provided is the 2017 HEDIS at a Glance Key Pediatric Measures. So what exactly is HEDIS? And HEDIS is a look backwards at the year or year prior to your practice. So it's this retrospective review, and it's a look at all the services and clinical care that was provided for your patients in your office. What I thought might be helpful to do, and the next few slides that I have come from the handout that I just mentioned, the HEDIS measure handout. So I wanted to just highlight, I just pulled out a couple of these. This comes directly from that handout. a couple of the measures that are on there and that may be things that many of you are working on. So one of the things that is out there, and I really like this handout because it has the actual measure, and then it also has documentation tips and tells you different codes that you can be using. So you can work with, make sure that you have the right codes logged, in your EHR, and that you're, coding correctly. So the first 15 months, 6 times before, people refer to this one as 6 and 15. So it's based on the seeing children, at birth, 1 month, 2, 4, 6, 12, 15. So you have to see them within 6 times before that 15-month birthday. It's been nice with this measure because this measure allows us to not have to necessarily see kids right on the birthday, which sometimes can be challenging for families and practices. But it also is important. I know I can speak to my experience that when we were looking at our quality report card with one payer, I knew that I had seen some of these kids actually more than that amount because they had been sick, and many of them were receiving Synagis in my office. And what we realized is that sometimes some of the kids were getting coded as follow-up visits for Synagis when really it was an HMV with me, and so there was a couple of times where we didn't hit this measure. And so it fostered us to do a quality improvement project in our office where as part of our chart review and huddle, we actually just have one of our nurses who's doing the chart review help us just check visit type. Because it was sort of silly. It was work. We had already done the work. We saw these kids, and we missed the mark just because of the way we coded. So it's just an example of something for you to be thinking about. Also, hopefully you have front desk staff when you have, it seems pretty, intuitive. Oh, yeah, from age 3 to 6, you're going to have at least one well-child visit with a PCP during the measurement year. But you really want to make sure everyone at your front staff is trained. Those are often the folks that are scheduling these appointments, or if you have a referral coordinator. Payers won't pay for visits even if it's a week before the next birthday. So you really, and you're not going to hit that quality score. I'm thinking about that also with adolescents who are called out, especially in the HEDIS measure mark, because adolescents tend to be not as compliant with their well visits. So it's really important to be thinking about in your practice having, that's why quality improvement is not just about the clinicians, it's about the whole staff. And often your front staff or administrative folks have very unique roles in ensuring that you hit these measures, and it often requires a team. It doesn't just require the person who's rendering the service and submitting the code, but all the steps that need to happen to get to that point are really important. So that's just one measure, a HEDIS measure I wanted to highlight. The other was the dental visit. So another HEDIS measure is patients need to have at least one dental visit during the measurement year for children ages 2 to 20 years. And so they need to have this annual dental visit. And so, giving some thought to this, and, sometimes I think practice is a struggle because this isn't something that, most of us don't have, like, dental chairs in our office. Co-located dental in our office is a pretty rare find. I know I've heard lately that there are some folks that are that have, like, dental hygienists. I mean, it's pretty rare, but, we do fluoride varnish, or we help families get appointments. But this is one that some physicians say, it's beyond my control. So what can you do? And I know that we had a report meeting with one of the payers last year, one of the Medicaid players in my neck of the woods, and we were talking about how there had been this really great initiative in Philadelphia where they brought a mobile dental van to a bunch of the schools. And so a lot of the kids were getting their dental visits at school, which is awesome. And so patient-centered, it's like getting these kids there. I don't know how often some of the kids thought it was, but, they were getting their oral health, and it saved families an appointment. Parents didn't have to take off work. But what we found was that there was a glitch in the system, and that this was happening. It wasn't something that we even could see, but it wasn't getting reported to the payers. So we were getting dinged on our quality report cards for something that the kids were getting the service. We'd see them. We'd go to our notes. We'd look in there, and it would say, Johnny said he got, and Mom said he got his dental visit, and she signed off on the permission. She knew it happened. But because their Medicaid plan wasn't getting, and had no way of getting a record of that, they were dinging us. So sometimes it's why, again, it's so important to have family partnerships or understand what's going on. And we had a really candid conversation, a very productive conversation with our payer about how to address that as an issue. So begin to think, proactively. This to me also is a HEDIS measure that would be a great one to talk about with parent partners and ask their opinions. Maybe there's a go-to dentist in your area that you can work collaboratively with. I'm sure a lot of the families would have great ideas on how to help you meet this measure. The other one is, that I just was going to highlight for a minute was the HEDIS measure around vaccinations, because, there's lots of the big sort of care gap that we pull reports constantly on is the immunizations that must occur before the second birthday. And in your packet, we have a handout on the ACIP guidelines. It's a nice printout that you can have in your office. It has all the guidelines for vaccinations as well as the Bright Futures. It's the nice chart, the recommendations for pediatric preventive health care, the most recent one. So it's a nice chart that you might want to hang up. But it's they're the most recent guidelines as of January 17th. So just to make you aware that those handouts are available for you as well in your toolkit. But getting back to this guideline, you want to run regular reports. We have someone that we work with in our system who's kind of like our EHR data person. And so we've been talking about one of the things we tried to do to address one of these measures was just have regular reports run, not just when we think about it. So every 3 months, run our care gap report on this measure. Sometimes we find that, particularly like for vaccines for children, it's all reported through your billing system. So sometimes there's inconsistencies. I will tell you, and I don't want to vilify the payers, I never would, but I can tell you that we definitely have had discrepancies with data. These quality report cards that you receive from your payers are absolutely informed by the payer data. So sometimes even with the vaccines, and we would go back to our record, and we did a root cause once in one of our meetings, and we knew that the information was wrong. We could show in the immunization record that it was administered. And it turned out there were some glitches in, the reporting and the way it got billed and the way it was getting logged in VFC, and then there's the immunization registry. So I encourage you when you're looking at these report cards to also, not be overly paranoid about it, but also know that sometimes the data is not always accurate you receive from them, and the payers, that is. And so that's why you want to be able to have a deeper dive and have a handle on how you might access the same data in your own EHR or billing system. So, you want to make sure that all those kinks are worked out. Dr. Cressley is going to talk a little bit more about the regulatory requirements around meaningful use of MACRA. But a lot of you have been looking at PCMH recognition. And that's really wonderful, and it aligns a lot with the work you've done with Medical Home. I wanted to just take a minute to talk about the triple aim, which I alluded to earlier, to quadruple aim. So this comes from Dr. Berwick from the Institute of Healthcare Improvement, and I talked about it earlier. The triple aim is the better health for the individuals and population, and then we lower costs through this improvement. And very recently, the quadruple aim was coined by Dr. Bodenheimer. I encourage you to read, if you're interested in this, things written by either one of them, Berwick or Bodenheimer. But the quadruple aim adds this fourth point, which was improved provider satisfaction. And it really is something that's been written about more and more in quality improvement, is that as you embark on these initiatives and you do these things, are you connected to or assessing or thinking about your whole office team? And, there's lots written about how in addition to be surveying our patients, we should be getting feedback and surveying our whole practice team from front staff to physician to make improvements. So when we have improved practice satisfaction, you can collaborate with other practices. Often if you can address some of the gaps or some of the feedback, you can often have your team become even higher functioning. It might broaden the picture. It might be that your front staff doesn't really understand that every time they miscode a visit type, it's actually costing you money. So it's really great to explain why these initiatives are important, what they mean. Sometimes you might have higher overall job satisfaction, and you can hopefully retain key staff that you want to stay on. And always remember that you want to be involving family members as part of this team, and that hopefully as you're improving the practice satisfaction, you're improving the family satisfaction as well. So at this time, I wanted to flip over to another audience poll and get you guys thinking about this idea of practice satisfaction. So how many of you are surveying your practice and or office staff team? And if you could flip that poll over for us, Iris, we want to get a sense of if you guys are doing this. So is it regularly that you are surveying them, occasionally? Maybe it's not scheduled. Maybe you did it one time. Have you thought about it? Have you ever gotten their feedback? Great. It looks like here that a lot of us are have thought about it or maybe did it, but haven't been necessarily doing it regularly. So again, this our work here on this webinar today is really meant not to admonish anybody. It's just to get you thinking about things that you can do. What can you do in your office next Tuesday? What are things you can do to prep for that big quality improvement boot camp? Dr. Cressley, I wanted you to have the slide and see it because it goes pretty quick in the video, but it's, she's going to be talking about maintenance of certification part 4. So it's important, especially to get some of your physicians, for those of you that are either on or if you're an office manager or someone trying to get your physicians jazzed. We all have to do maintenance of certification, quality improvement, so this might be the carrot to get them on the bus. Dr. Cressley's going to talk a bit about evaluating for value-based payment, and so just remember that as you start thinking about the data. I talked about the payer data. You have EHR data from your health record. You can get data on the cost, how much things cost, data on outcomes, family feedback. You think about your immunization records that you have or whether they come from a state immunization or vaccine for children's registry. Think about where you might get some of this data and how to collect it. So with that, we're going to launch into the video. Iris, I can read the questions if you want to tee up the video, but we wanted you to be thinking about, your biggest struggle. Can you think about some team members who would benefit from a broader vision, as I mentioned? How might you change their perspective? And think about the quadruple aim and triple aim that I showed and ways that you might want to address that in your practice. And with that, we're going to let Dr. Cressley kind of wrap up our second part with this next video.
Welcome back to this 3-part series on quality improvement, presented on behalf of the PA chapter of the AAP and the PA Medical Home Initiative. The Pennsylvania Medical Home Initiative is a project of the Pennsylvania Department of Health in partnership with the Pennsylvania chapter of the American Academy of Pediatrics. This is meant to be an introduction and provide you with background information so you can effectively embark on quality improvement in your practice. Part 2 in our series will look at quality improvement and what's in it for you. Our learning objectives for this second segment are to identify the reasons to become involved in QI, to understand the ROI, or return on investment, for quality improvement participation, and to begin to envision what quality improvement can bring to your practice through your participation. You may be asking yourself why you should get involved in quality improvement activities in the first place. Some or all of these reasons may be relevant to you, but we will examine them in more detail individually. Caring for our patients is the core of everything we do. Sometimes our intentions are great, but our delivery and performance isn't as good as we know it can be. To start with, you can't improve what you don't measure. Many of us have the Lake Woebegone effect, where we think our performance is above average. But when we look at the real numbers, we come up shorter than we thought. This can be disheartening and overwhelming, but it doesn't have to be if we stay focused on our patients. We should work on improving care using evidence-based guidelines, like Bright Futures for well visits and ACIP recommendations for vaccines. Patient safety should always be in the back of our minds when changing processes or working to improve. There's good data to show that patients and families who are engaged in their care are more likely to follow our recommendations and have better outcomes. One of our biggest challenges is to coordinate care with other parts of the larger healthcare system. And we must remember that our patients come with unique needs, and we should strive to meet them where they are and address their needs in a way that is relevant and accessible to their family. We touched briefly on the pay for performance in the previous presentation. Often additional dollars brought into the practice can help support the ongoing work of quality improvement and create a sustainable business model. For example, P4P bonus dollars might allow you to add a care coordinator or recall coordinator to help bring patients in to address gaps in care. Providing evidence-based services, such as well visits according to Bright Futures, adds additional patient visits to your practice. And in the case of well visits, it's without cost to the family. There are still practices across the state who have not started doing 30-month well visits or autism screening. Are you recalling patients with asthma or ADHD in accordance with clinical practice guidelines? Do you code and submit payment for review of Vanderbilt's and developmental screening or for fluoride varnish? Many of the private payers give P4P bonuses to practices because they have to report their plan performance on HEDIS measures to NCQA. How do they perform well? They need you to provide the services so that their numbers look good compared to their competition with other payers. They aren't seeing the patients, we are. They need us. There have been practices who use their high performance on quality measures to negotiate improved fee schedules for their own practice. The more covered lives you have of their insureds and the higher quality you can demonstrate, the more leverage you have for your practice. Not all of us meet the criteria to qualify for meaningful use or applied for NCQA patient-centered medical home recognition. But much of our healthcare system has some data submission requirements to meet regulatory mandates. Whether or not the programs on this slide apply to you, remember they are driving much of the change in how we all get paid, and pay for value means high quality at a reasonable cost. That high quality matters regardless of your personal regulatory reporting burden. Most practices that have undergone any degree of practice transformation using quality improvement as its framework and putting the patient at the center have reported improved practice satisfaction. Collaborating with other practices and sharing successes and strategies to tackle challenges makes us all know that we are not going this alone. Quality improvement requires teamwork, which we will explore more in part 3 of this series. You can't do QI alone sitting in front of your computer. It forces us to think across the practice more broadly, and often team members begin to see the bigger picture and their crucial role in the team. They understand their value in improving care for children and begin to think of ways they can contribute to solutions. The nursing staff in my office has much higher satisfaction as they've changed their thought process from, I need to give this immunization to this child, to, how can I help this child and their family today and make sure they are getting everything they need? Is this a young mom who is Spanish speaking and I can give her instructions on how to take a temperature and what to expect from the vaccines and how much Tylenol to give if there's a fever, so she feels comfortable and won't panic or go to the ER if the child gets a fever in the next 24 hours? Practices who involve family members as part of their team have universally seen the value in having that family perspective. We may think we know how the patient feels, what they need, what they want, but unless we actually ask and listen, we often have unmet expectations, and that results in suboptimal outcomes. For many of us, maintenance of certification feels like an additional burden. Regardless of your personal feelings, for now, it's what we have. The MOC Part 4 improvement in practice options are all focused on improving quality. The options have gotten more robust, and there is now the ability to create your own QI project and/or use your medical home recognition, which requires quality improvement, to meet this requirement. You can contact the ABP or the chapter for specific questions. So many of us have heard about the triple aim in healthcare: achieving better outcomes for patients and populations, lowering costs of care, or at least improving the value of what we do, and improving the patient experience. Recently, the fourth aim of improved clinician experience has been added. I believe that extends to all members of the healthcare team, from the front desk to the care coordinators, to the MAs, and to the physicians. When we put the patient and family at the center, and together we work to improve, we all go home feeling like we made a difference, and it improves our experience in delivering that care. This concludes the second in the 3-part series on quality improvement. We hope you agree that there is demonstrable return on investment for embarking on quality improvement in your practice and what you can hope to achieve through participation. We encourage you to contemplate and discuss further as time allows.
Great, thank you, Iris. So with that, we're going to embark on the third and final leg of our webinar, what is really involved in quality improvement. So the objectives for this are really to talk about what it takes to be successful at quality improvement. And I'm going to focus on various pedagogies and thinking of quality improvement in practice, but I'm going to spend probably the most time on PDSA cycles as the center of quality improvement and envision what it will take to be successful in your practice. So we talked a little bit about this. Quality is a way of thinking about work. It's a way of achieving excellence, nothing else. And we talked about the Institute of Medicine definition of quality, and that degree to which the healthcare services for individuals and populations increase the likelihood of desired health outcomes that are consistent with current professional knowledge. So that's where you want to start. You've got the evidence base, the current knowledge, and you're trying to achieve those outcomes. And you've got to shoot for the stars. You've got to shoot for 100%. You might not get there, but you want to shoot for it as your goal and get somewhere close. So when you think about a successful QI program in your practice, it always incorporates the following 4 key principles. QI work really addresses systems and the processes. So you're looking at your whole office as a system, but the workflows and how it happens from the beginning to soup to nuts, from the second a family calls your office or accesses the portal or walks through the door. And then what happens through their entire experience in getting back to where they're seen with the clinician and the whole checkout and exit process. You really want to look at the processes, but always focus on the patients and their experience and the families. And the third important principle is really focus on being part of the team so that everyone recognizes their role and that their role is important, and including your family as part of that team. And the fourth principle is focusing on the use of data. As we said, you can't improve on things you don't measure. So I like food, so I have to address the ingredient analogy. And the key ingredients in QI really are the clinical knowledge and experience. So you need someone in the office who is aware of what the practice guidelines are, aware of your patient population, get some of the QI basic concepts down, and then really look at everything from the systems approach. So in doing that, and Dr. Kresge's going to talk a little bit more about this in her video portion for this leg, but Donna Bedian, where the source is, I don't think that he's alive anymore, but he talked about this framework, which is really structure, process, and outcomes. And so it's this framework on how we can approach quality improvement. And so the structure really is the people in your office and your EHR, and that process is what is done and how it's done. And the outcome is really what you see in terms of the patient experience, their outcome, or the family satisfaction. So there's several different models that I wanted to talk about as part of this webinar to get you thinking and be able to do deeper dives in the November conference. But one of the first ones that's probably one of the most well-known is PDSA, Plan, Do, Study, Act. And I think some of you that have been part of our Medical Home Network have engaged. We've done PDSA cycles in practice, and they actually have, worksheets, Plan, Do, Study, Act worksheets that you can actually walk through in your work. And we'll certainly be sharing some of those with you at the Quality Improvement Conference. There's also something called the Lean model, which I'll spend a few minutes on, which is based on time and cost and efficiency and what the customer wants. There's also Six Sigma, which is a measurement-based strategy that focuses on existing processes and creating new processes. And the Lean Six Sigma principles, which many people are familiar with because of they were used in Toyota and their Kaizen principles. I just really will spend a brief amount of time on some of the others just to make you aware that they exist and that you understand some of the core principles in case any of you want to pursue them further. So to launch into the PDSA cycle, the Plan, Do, Study, Act, you really are starting with plans. So you have some objectives and some questions and predictions. And, thinking about what will happen if we try something different, who are we looking at, how are we doing this, when are we going to do it, so you really want to establish a time frame. And then you're going to jump into it. You're going to get right into it like Sean T. You're going to carry out the plan. You're going to document the problems. And you're really going to try it. You're going to get everyone engaged for a specified period of time for a very focused project. And then, the key is studying it, that measurement, right? So you want to know, did it work? Did it make a difference? That's why you need the data. You need to see, did we go from 50% where we started with HPV vaccinations to up to 70? What improvement did it make in this intervention? And you want to look at what you thought. So maybe you thought that you'd get to 80% improvement in HPV vaccination, but you only hit 65, that your delta was only 15 instead of 30. And then you want to think about why that is and sit down as a team and sort of reflect on what could have gone differently, what could have informed why your delta wasn't quite as much as you anticipated. And then act. And that's the key in the quality improvement, is that you're never done. It's not like, okay, well, we hit 65 and now we're just going to stop there. No, you take what you learned. You think about the challenges. You think about what worked, what didn't work. Maybe you go back to your family members as well as you're reporting these study results and see if they have any ideas on how to implement the next cycle. Okay, maybe we're going to go from 65, and maybe we think we're just going to move the needle to 70 next time, but what are we going to do? So I'm going to walk you through a little bit more in depth in these processes, and they are now going to, when you think about setting those aims, so you want to really sit down and think about as a team what aim and what you're going to focus on. And as I mentioned earlier, that it should be very time specific. So, you're going to focus on a new, quality improvement approach to improving HPV vaccinations, and maybe you're going to implement your intervention over a 3-month period. So you're going to start on this day and we're going to stop on this day. You want to have a very discrete time frame. And you want to measure it. I mean, the vaccine one's probably an easier example because either the child got it or they didn't. But you want to think about missed opportunities. So, you want to look at who was eligible as well. It's not just, the overall vaccination rate, but think about your measurement. Really, the proof is in the pudding of how many kids came in who could have gotten it or were eligible for it and didn't get it. So that's when you want to think about how you're measuring things and what you're looking at. And you want to define the specific population. So in some cases of vaccines, it may just be age-related. Maybe you want to start your process on just girls and not boys, or look at which one you have more room to improve. So that's really when you think about your aims, and you want to establish your measures. So you want to use quantitative measures to determine if the change actually led to an improvement. So an example maybe of family satisfaction is one that's a little less straightforward. You might have a family satisfaction survey that you want to improve overall family satisfaction by 80%. But when you think about, a survey that you're using, you may want to look at an overall score. You may want to look at a couple of questions. So really sit down as a team and think about what is most meaningful to you. Think about selecting the change to change it. So all improvement requires change, but not all change results in improvement. So it might be, for example, that you have implemented a great process that improves the time, that maybe you're using. I know now we try to use our EHR way better to let our medical assistants know that the child is ready for vaccines. And so maybe, maybe you're, I know in our office it's definitely improved flow for the physicians to use the sort of location tracker and change a particular field in our EHR to say, provider in room to patient ready for vaccines, and they can easily go into the next room and start seeing a patient. So that definitely may have improved the patient flow, the time that a patient is in my office and the efficiency, but that alone may not actually have improved the HPV vaccination rate. So my point is that sometimes you're actually, the quality improvement cycle or the PDSA cycle may in fact have improved some workflow, some processes, some secondary gain in your office, but it may not necessarily have contributed to the bottom line of what you sought out to measure. So it's not necessarily a bad thing. It's just something to be aware of and to discuss. So think about the changes in what you're doing and, what is most likely to result in the improvement that you're after. And then, as I mentioned earlier, after you test the change on a small scale, you want to learn from each test and you want to refine it through several cycles. And then you might want to start, maybe you were starting with HPV vaccine and implementing a new workflow. Maybe you just start with one clinician, or maybe you just do it on one day of clinic. See if it works before you turn your whole process inside out, change your entire EHR workflow, your entire clinic workflow. And maybe once you've achieved your desirable outcomes and you see, okay, just with doing this we can improve vaccine rates by 15%, then you roll it out to the whole clinic when you're confident that it's a change cycle that's worth making standard or institutionalizing it. And one thing that's really important is to ensure sustainability. You don't want to embark on quality improvement or improve your quality improvement score or report card or improve vaccination rate or improve dental visits or create a system that is so dependent on having a student in your waiting room and that student intern is only there for 1 year. Or what happens when the student's internship is done? You don't want to create something that the bottom falls out and then you don't have any sustainability. So you want to have a pilot and you want to look at how you can spread it and sustain it. That's really, really important. So as you're thinking about quality improvement development, you want to identify a project aim in one of your first essential steps. And you want to develop that plan to achieve the aim, and that should be a team effort. Maybe the quality improvement leader comes to a meeting with some of this outlined, but they definitely have thought, as a team, you're thinking about the aims, that aim and the roles and responsibilities, the improvement methods, where you're going to get the data, how long you're going to do it for, and then really think about what outcome you're focusing on and make sure that you're using your data to identify which improvement you most want to focus on. I want to shift into for a minute the lean, just so that you have some familiarity with some of these terms and the other approaches to quality improvement. So the lean, which I mentioned earlier, is really based on two themes of continuous elimination of waste and respect for people and society. So the key principles are really that value is in the eye of the consumer or the customer, and it really does highlight the idea of making flow without interruption. So you're improving workflow and you're standardizing work processes, and the ultimate goal is to pursue perfection. It's kind of interesting that a lot of these processes really stem upon some of the other industries outside healthcare, which I mentioned earlier. So the lean really is, comes from this Toyota manufacturing culture where you're stopping and fixing the problem as soon as it's identified. And you're really looking at this whole idea, as I mentioned earlier, your PDSA is like, it's not one and done. So you're measuring it, you're changing it, you're measuring it, you're changing it, you're going back. Some of the thinking and some of the fundamentals are cut across the different approaches, or whether you're using PDSA, Lean, or Six Sigma. The idea is that you're measuring and taking what you learn from that and changing it. The other one that you probably have heard of is the Six Sigma, and that focuses to eliminate the defects. So, in the other industries, it says non-conformity of a product or service to live to its expectations, and it's really very focused in that, they have variations that result in less than 3.4 parts per million defects. The idea is that you have this systematic management approach, and you're reducing sources of variation and improving reliability. So the idea is that you're focusing on the customer, you're focusing on the finances and the bottom line. It's obviously, a little more easily, adapted to like an assembly line and making a car, but I think it's relevant in practice because you look at the family experience, people who are Six Sigma certified. It's a very rigorous training in that you might have heard someone say I'm a Six Sigma black belt. There's this very intense training, but it's great project management. People will talk about going through these workouts where you sit down with a large group, you identify some processes, and you kind of work through the concepts strategically. And they use statistics, so you really drill down to like the percentages, and you try to mistake-proof things as you go forward. So it really looks at the sustainability in this Lean Six Sigma. I wanted to also introduce a concept in the discussion today, something called a root cause analysis. So I often think about root cause analyses even in our everyday life, and I think about looking at, root cause analyses on how things even happen or fail to happen in your house, like when my kids forget to walk my dog, and trying to think about what might have led to why that didn't happen. But I think in practice and thinking about a root cause when things go wrong, it's a really great approach to think about, because you're not blaming. You aren't looking at individuals and their performance, but you're looking at the causal factors that cause the variation. And you're learning from the mistakes, you're learning from the consequences, and you're looking at the systems and the processes. So you identify potential improvement, and you're trying to make sure that this doesn't happen again. In the hospitals, many of you are familiar with like the M&M, the Morbidity and Mortality Conferences, where they look at where maybe a patient died or there was a mistake made in a sentinel event. And so it's really a time where everyone kind of comes up and you walk through what happened. And so sometimes you might just want to call, something a root cause analysis. Let's look at why this happened. The other thing to think about that's often used in quality improvement is something called run charts. The example I use here and why I think a run chart is really helpful is because it's at a glance, it's a snapshot of what you've done. This might be a way that you want to present the quality improvement data. So this example is around care plans. So let's just say that you embarked on over time on the horizontal axis. You might plot out over, let's say it's over 6 months, and your goal was to increase the number of care plans that any given clinician completed and engaged families in that process. And so what you would do is plot the actual number of care plans that were completed over time, but then you would examine and look at time. Okay, it was in month 2 that we implemented this process where the nurse came into the middle of a visit and they reminded the clinician to do the care plan. And then it was in month 4 that we implemented a change process where the medical assistant printed out the care plan and handed it to the clinician to go back in the room and ask for the family feedback. And maybe it was month 6 that we implemented process change 3. So the idea of those process changes is that you list where you had the various interventions. And then you see how those various interventions impacted the overall number of care plans. As you can see in this example, it looked like process change 1 really brought folks from had the steepest slope, the longest line, resulted in, the most significant change. But you still went from, 2 to almost 7 over time. And so, maybe it's that you want to retain all 3 change processes or just focus on the one that had the most dramatic improvement. Or maybe you look at a change process and when it happened and there was no change, the care plan, we don't see that here, but let's say that the care plan number stayed flat, then you might be a way to know that that particular change process or intervention was not effective. So it's very easy to plot out. You can do it with various software, but sometimes it's helpful for practices very quickly to show your staff and also maybe be very incentivizing for the positive outcomes that their efforts cause. The other thing that you might hear about in quality improvement is something called a key driver diagram. And these are sometimes really fun, a little nerdy, but I think really fun things that help you organize thoughts and discussions. And so the idea is that this blank template here is that you start with an aim. And so maybe that aim is, improving the number of care plans that were completed in your office. And so what are the primary drivers of that aim? So it might be that, the provider, the primary drivers are really thinking about the areas that show we need to address this aim. So that if, to achieve family-centered care, we need to include care plans because that's the way we incorporate families' goals. And the secondary drivers are the actions that we can take. So maybe it's, getting the nurses to come into the room. Maybe it's embedding a care plan template in the EHR so they're easy to fill out and they're pre-populated. Maybe it's printing out a copy of the care plan when we give them immunizations. Maybe it's talking to everyone in the office to fill out part of the care plan. Maybe it's getting our parent partner to remind the practitioners to complete the care plan. And then the change ideas are really the suggestions to help us implement those drivers. So that may be where you're engaging the parents, that may be where you're engaging health IT, maybe it's approaching your payers to get payment for the care plans, but it's really thinking about all the change that you can do to help you implement. So I think key driver diagrams are helpful because it gives you that framework rather than just listing things out on a piece of paper or, you're sitting in a meeting, sometimes everyone's throwing out these ideas. This allows you to sort of streamline it, put it all into a package and have everyone share. I included a couple examples of key driver diagrams. So, just the idea is just to, I sort of walked you through one with the care plans, but you really, if you're really interested in doing these, there's blank templates and there's lots of examples on the internet. Being patient-focused is key. So I think that, thinking about that and really just wanted to highlight that we want to make sure that patients' needs and expectations always need to be met. They must also involve population management. You can't just focus on who you're seeing in your office. You want to look at patients who have gaps in care. So you want to see and take a look at that list of patients that the payer sends you that you may or may not have seen and figure out how to get them in. Maybe they haven't been seen in 2 years. And I think that a lot of times when you are thinking about this, you want to engage those family representatives to help you think about it. You know that a lot of the work we've done with medical home is we always talk about one of the key constructs is your medical home team. So start with your medical home practice team. Think about the responsibility of every member and every contributing member. Everyone brings a unique perspective and they tell you how things get done, and that's where you're going to have your sustainability. And everyone has a skill set and adds to the team ideas about their job and what they do. And so it really, think about establishing a QI team as a subsidiary of that group and keep the child and family at the center of all that. I also wanted to highlight that we have in your packet the handout from the pediatrics. It actually came out very recently from Pediatrics. It's a great article on guiding principles for team-based pediatric care. And that's where some of this comes from. So there's an AAP news article as well as an article that's a handout for all of you guys to take a look at. So data is power, and think about, what's happening from what really is happening, as I mentioned earlier, and always remember you need your baseline, and you want to allow to monitor and think about, as I gave you some examples, about what's actually leading to change or what might not be. And also, the data that you look at actually allows you to look maybe across different sites. Maybe you have 2 or 3 offices, and it might be that one of your sites performs better at a certain measure. And what is it? Is it related to the nurse that's there? Is it related to the patient population? And really start looking at those things. Qualitative information can be as important as quantitative. And so remember that Dr. Cressley will talk a little bit more about this, but think about the focus group discussions. Think about how you can get, suggestion boxes, but also just observing. Dr. Cressley will talk a little bit about, hanging out in your office and following a patient through and thinking a little bit about measurement. So I want to talk about leadership for a minute, and I think that many of you that are on this call as part of medical home teams have been your medical home leader, and so you want to make sure that you have leadership within QI. Maybe there's someone in your office who's, your QI office manager, your leader. You want to have someone who's clearly committed, that thinks about the bigger picture in your practice, that can drill down to the short and long term, and really cultivates that spirit of QI and develops the team members and their skills, and also really fosters effective communication between the staff and all the teams. You want to have that team buy-in. It's essential. Everyone has to understand why you're doing it, and you want to make sure they're supported and they're monitored. You want to see that maybe they get a little bit of protected time to roll things out, but you want to ensure that buy-in in your practice. And remember, as I said, that there's no ceiling. You want to make sure that you have that continuous aspect. There's always room to improve. There's always room to sit down and say, hey, we did great. It's not always about, suboptimal performance or being chastising. It's really about the team effort. And you want to make sure that you pace it. You can't put so much on a team that's already trying to, get through practice and run a busy practice in the middle of winter. Think about when you're setting up to launch QI that you're expanding your existing medical home team that's clearly highly functioning because you're already thinking about this. Maybe assign a coordinator. Maybe you already have someone identified. But like other things, in order to move them forward, you need to have meetings with agendas. Include your family members there, and always just remember you're reevaluating and you're adjusting. I think that I wanted to, drill down to, I'm very into implementation guides, and think that the setting up to launch QI, as you sit down, you develop your objectives, you assign responsibilities in that meeting, you're defining the components, how are you going to track it in your practice, where are you getting the data from, is it your own data, is it the payer data, how are you going to measure it, how are you going to roll out the process, are you going to use a PDSA cycle? We included as one of your handouts the PDSA cycle template, so you can take a look at that and actually just download that and use that tomorrow if you wanted. You want to review the PDSA cycles and your progress and your quality report cards quarterly and monthly, and you want to really think about ways that you can take action to continue to improve because you're never done. So I think that when you think about how you can be prepared to do QI and value-based healthcare, as I said, you want to look at that systems approach to using your data. You want to monitor your own panel as your whole practice, but also look at individual clinicians. You want to think about how your practice change really does influence quality, and you want to use your measure to improve quality. That culture is really important, as we talked about. That's how you achieve system change. You want to train your staff, so maybe you have them listen to webinars, maybe send them to a conference. Just get them involved in the importance, and you want to internally build the analytic capabilities to look at that total cost. So you're reducing redundancy and waste, as we talked about earlier. And you want to review those payer feedback reports that you're getting and have standard times that you sit down and talk about them. Think about your EHR as a critical tool in your QI journey. Your EHR really can be your map. So as you think about the quality metrics that you have, we just recently had the Edinburgh postpartum depression screen put in electronically in our EHR, and it's been great. I saw a patient yesterday, and I was able to go back. Even though we scanned the paper copies in, it's awesome having I enter in them electronically in the field, so at a glance I can rescreen a mom, and I have it right at my fingertips. You design templates in clinic flow. You're training your team. It doesn't always have to be the physician who's entering things in. Think about your staff and who can enter it in and who can pull the data. And you're evaluated, and maybe there's something missing from your template, so you might redesign that template. Or maybe you're redesigning the flow in your office to accomplish it better. I wanted to highlight this as I'm coming close to a close of the webinar, but I think some of this really kind of, I hope, inspired you to think about quality improvement. And I think that why I think quality improvement is different, and it's important to think about this as informal improvement, meaning like you're just going to think about it or do it. I wanted to highlight the differences. So if quality improvement is systematic, you're changing the systems approach at your practice level. Informal improvement is just an individual or a group. It would just be like Renee saying, I'm going to do better on remembering to vaccinate every kid with HPV as I see patients today. But that's not really going to be sustainable, or it's not going to really move the needle, right? QI has a data-guided and knowledge-informed, but informal improvement maybe knowledge-informed, but you usually aren't reporting data. It's just Renee with her goal. QI is experiential, as is informal improvement, but informal improvement often can be anecdotal. It could just be me saying, I don't think I've done a good job vaccinating with HPV, but I'm not actually looking at the data showing what my rates are. They're both innovative, but quality improvement employs formal, explicit methodologies, as we talked about, PDSA, Lean Six Sigma. And informal improvement is more exactly what it says, informal. I'm just going to do it better and write myself a sticky on who needs HPV. Quality improvement is continuous, which means it's sustainable, whereas informal improvement is episodic. I might have an off day in clinic or be really busy, and if I don't have a workflow or a standard process, I might still forget that I'm focusing on improving HPV vaccine rates. QI is a core responsibility of everyone, all the healthcare professionals, and they know what their unique role is. Whereas informal improvement, there's no explicit responsibility. Often it's hierarchical and falling on the office manager or the medical director. And again, QI is systems change, whereas informal improvement is individual. So remember that quality is a system-wide issue, and individual performance is rarely successful alone. That's why you really need to have it permeate. It might start, that small test of change might start at small scale with one clinician, but you've got to get them to be one team member that shares it to the whole team. So you might be the wentz in your office, but you want to make sure that you've got your whole lineup and your running backs and your offensive tackle. Everybody's already in line. You can learn a lot from the Eagles and how they do this, especially for those of you that are gold on this call. So it requires team skills. It requires collaboration. It requires meeting skills and meeting the goals, actually meeting goals in a meeting. So there's actually some really good research and literature on how to run effective meetings and how to have agendas and things like that. And really the team values all the perspectives. There's no I in team, so everybody on the team is valuable. So we have a final video that we can tee up, and I can just throw out some of our last questions. So this is Dr. Kresley's last video, and we're really going to talk a little bit about, think about who you're going to include in your QI team and how you've been teed up in medical home to incorporate parent partners in your practice, and how, hopefully from this, what you've been doing in your practice and what you could potentially have adjusted or abandoned. And really the ultimate goal for us is to have you be thinking about the big QI boot camp, which we'll talk about after the video, and how some of the information from this webinar might have you prepared for that conference. Thank you, Iris.
Welcome back to this three-part series on quality improvement presented on behalf of the PA chapter of the AAP and the Pennsylvania Medical Home Initiative. The Pennsylvania Medical Home Initiative is a project of the Pennsylvania Department of Health in partnership with the Pennsylvania chapter of the American Academy of Pediatrics. This is meant to be an introduction and provide you with background information so you can effectively embark on quality improvement in your practice. Part 3 and the final in our series will look at what's involved in quality improvement. Our learning objectives for this third segment are to identify what it takes to be successful at quality improvement, to understand the PDSA cycle of continuous quality improvement, and to envision what it will take to be successful in your practice. Quality improvement that is successful incorporates attention to people, processes, and technology. Key principles include systems and processes, keeping the patient and family at the center, reinforcing the team it takes to do the work, and focusing on the wise use of the data. This is a great schemata from the HRSA Quality Toolbox. That's HRSA. I encourage you to explore the tools and information that are available on their website. There has been thoughtful study of what it actually takes to improve and sustain quality, and you should not reinvent the wheel in your practice. Take advantage of tools in the public domain to educate yourself and your QI leaders in your practice. The inputs to the process are outlined above, and almost all QI projects involve the people, the infrastructure you have in place, materials, be they patient education materials, vaccines, etc., and the technology. The processes you put in place or the activities of your team include not only what's done, but how it's done. Together, the resources and the activities are what drive your results. Most of you should be familiar with this plan, do, study, act of the PDSA cycle of quality improvement. True QI cannot be accomplished without all 4 phases of this process. Planning without acting rarely results in improvement. I always plan to exercise to lose weight, but somehow when I don't find the time to make it happen, I shouldn't be surprised there's no improvement. If you have your plan translate to action, you really need to study what happens. If you're not looping back to assess the effects of what you've done, you may have a false sense of improvement or may have made things worse. I want to bring your attention to the act portion of this cycle. Notice that the default isn't always to widely adopt the plan you began with. Most times there are needs to adjust your original plan as you gain more information, or sometimes there's unintended consequences. This should be an iterative process and not one trip around the circle. I cannot stress enough the willingness to abandon a plan that simply isn't working the way you expected. This is very difficult to do when you've invested a large amount of time and energy. However, sometimes the timing isn't right, sometimes you need different perspectives, sometimes you don't have the right technology and you need to regroup. Sometimes additional training is needed. It's okay to abandon a plan that is not having the desired outcomes. You didn't fail. In many cases, you learned something very valuable that you can incorporate later. An example in my practice of a project which didn't work out as planned was our ADHD follow-up project. Doctors noticed we were refilling ADD meds for patients who hadn't been seen in a while, for our colleagues who were not in the office that day for one reason or another. Sometimes meds were being refilled for patients who hadn't been in over 6 months. Sometimes we would refuse to refill the prescription until they made a follow-up appointment. But the doctor who usually saw them felt like they were stable and didn't need to be seen every 3 months. We started a project where the person who saw the patient would write a task in the electronic health record for the appropriate follow-up visit. But this fell apart when doctors forgot to do it, or parents said they would call back when they had their calendar in front of them. In addition, the report which we could get out of the EHR didn't really reflect what we were trying to accomplish. And there wasn't actually agreement among the doctors on how often to see the patients back. We abandoned the project. We're going to regroup this fall using some care plan functionality in our EHR and start first with a discussion about who should be seen and when and how often. In the meantime, we've incorporated electronic prescribing of controlled substances in our workflow, and we're trying to figure out how to document checking the state controlled substance database as part of that process. Stay tuned for how this plays out. Many practices get in the habit of doing things in a certain way because they always have. If you are truly going to improve quality, you need to carefully reflect on your ability to meet your patients' needs and their expectations. You may be doing a great job of not giving antibiotics for URIs, but if your parents expect to leave with a prescription, they may not have a satisfactory experience. Do you then need an educational campaign on the appropriate use of antibiotics for your patients? What would that look like in your practice? Gone are the days when you can just take care of the patients who show up at your office for care. You should also be proactively reaching out to all of the patients who are attributable to your practice and get them in to receive appropriate services. There are certainly challenges in trying to find differences in what you think your active patient list is and what the payers do, but you must start with having a process to maintain your active patient lists so you're internally consistent. Involving patients and families in the process can be eye-opening. In my practice, we were going to add more evening physicals, but our mothers with young children told us that they would prefer early AM appointments and just drop their kids off at daycare a bit late and then head to work, rather than trying to reverse engineer the end of their workday with a cranky toddler in their car. Okay, it's time to admit that we can't individually do this work. We need to make teams that include all roles in our office. We also need to empower those teams to speak up, problem solve, and give our team members training and education to execute our plans. As practice leaders, we can decide that all missed appointments need to be followed up on and develop a protocol. But if we aren't actually doing that work, we need to listen to the folks who are doing it and get their input if we're going to succeed. We also need to understand that all patients don't need the same comprehensive team. Some patients' effective team members may not even work in our practice, like a social worker or a school nurse or a teacher for a particular patient. I encourage everyone to read the new team-based care policy statement from the National American Academy of Pediatrics. Data really is the key to practice empowerment. Having a way to see measured performance can be eye-opening. Most practices say, "This can't be my data." We tend to have a positive reflective memory and selectively forget the times where we made an exception or something didn't happen the way we knew it should. For example, our practice really thought we were good at writing generic medications for ADD. Then we ran the report. The report gave us actionable data. We could check the patients, see what each of us wrote, and lo and behold, we were writing more name brands than we thought. Why does this matter? In many cases, it's both a higher cost for the family, and most people have tiered copays based on formulary or generic prescribing, and the payer has a higher cost. You may think that that doesn't matter to us, but it should. Payers are painting profiles regarding the total cost of care. And in the eastern part of the state, we're actually getting bonus pay for performance dollars for keeping down the total cost of care and for generic prescribing. Two different buckets of money we can gain if we're good at this. Once you have a baseline, and you can do a root cause analysis to identify where and why gaps in performance happened, then you can develop your plan to improve and prioritize it. You can also then compare different office sites, your colleagues, provider to provider, use the information to work collaboratively to raise everyone's performance. Once you're a rock star, you have to make sure you don't slip and continue to monitor your data. Make sure you adopt, adjust, or abandon as needed. There is value in collecting feedback to see how you are doing. This can be a rating survey or simply comments. I encourage folks to not only measure qualitatively how you are doing with your patients, but also your practice team. Where do they see additional room for improvement? Are they struggling to make the plan work? Do they have a suggestion? It's also very helpful to sometimes be an observer. Be a fly on the wall. Follow a patient from your front desk to the exam room and back out. Did you deliver the way you strove to? Is there room for improvement? Don't use that information in a punitive way, but in a way that you can continue to improve. For data to be as valuable as possible, it needs to be clear and actionable. For every metric you submit information or query you run, you should know exactly what the numerators and denominators are. If you're trying to determine what percentage of your active patients had a well visit in the calendar year, how is active patient defined? Is it any patient who has an active status flag on the patient register? Is it any patient who has been seen at least once in the past 3 years? You also need to harmonize what you think is the right way to define the denominator and how the information is actually getting pulled from your EHR or practice management system or from the payer. What does it mean calendar year? Is it starting from today and looking back 365 days? The payer's likely defining it as any time from January 1 of the calendar year to December 31st of that same calendar year. Can your system replicate the query the payer's using? In most cases, the payer is getting everything from claims data, and you have more accurate information in your system. However, you need to negotiate with the payer an opportunity to provide additional information. Great example. For QI measures involving vaccination rates, what do you do with families that refuse specific vaccines? Will the payer allow you to submit additional supportive information, such as an AAP standard vaccine refusal form with a signature, in order to have those patients be included in their numerator? Someone should understand the data mapping in your system so you know where information is being pulled from in various reports. For example, if you're doing a QI project to improve follow-up on newborn screens, where's the query coming from? If you have the result in a scanned record, but it doesn't have the correct label, the computer may not count that scanned record. Many times scanned documents can't be counted in an electronic query because it's really just a picture, which a computer can't read. Do you also need to check a box or put an entry in a discrete data field for newborn screen reviewed in order for it to be counted? If so, who's going to be responsible for doing that? Actionable data is key. If you can identify with that query the patients that didn't get services, then go look at their charts and find out why. Did they no-show for an appointment and no one ever contacted them to reschedule? Are they really not active patients and moved 6 months ago? In order to begin to figure out how to improve, you need a clear understanding of why your baseline performance is what it is. In order to lead, you need to feel a common mission. Does your practice have a vision or mission statement? Is it shared by the entire practice? We know that our patients perform best if there is clear expectation setting and continual reinforcement. No setting is more difficult to improve than when not all the leaders are on the same page. How is the rest of the team supposed to know what to do if one doctor is recommending HPV vaccine at age 11 routinely, and another is telling parents it's okay to wait until high school? Some providers may need training on how to manage conflict and on shared decision-making with families. Some team members may need new skills. Empower everyone to work to their fullest potential, to speak freely when they are identifying barriers, and to work collaboratively with others to problem solve. A great leader makes sure all of this happens and works to make sure that communication not only happens, but it's effective. Posting notices that say, from now on, everyone must offer HPV vaccines at age 11 or get a refusal form signed, is not really likely to actually improve your HPV immunization rates in your practice. When you embark on quality improvement, it's essential that your entire practice team is bought in and brought along. If you have reluctant team members, identify their obstacles and work to overcome them. If they refuse to be part of a particular project, consider getting them on board something that they can feel good about. Everyone that is a key stakeholder in the improvement process must have a clear understanding of why you are doing it and believe in the project plan. It's not enough to have a kickoff meeting and get everyone psyched. You actually have to monitor that the buy-in is sustained and find ways along the way to support it. Consider setting short-term goals and having a practice ice cream party to celebrate your mini goals when you achieve them. Set yourself up for success. Especially in the beginning, set small goals that are realistically attainable so the team can feel good about their work. This slide says it all. We are always a work in progress. There is always something more we can do or another project to improve. But celebrate those small successes. Don't talk about failure. Talk about barriers to success. What got in the way, why, and how can we learn from it? Even if you get to what you think is the highest possible goal, keep monitoring it and be mindful of thanking folks for the work that they are doing to sustain the achievement. Now that you're getting excited about QI, remember that doing too much at one time is exhausting and can even result in compromise in patient safety. Change should be paced, manageable, and it's okay to take a breather for a while if you have done some great work. Encourage team members to think outside the box. Some of your youngest or newest staff may have some of the best ideas. Some of it may come from when they trained, and they were thinking to themselves, why in the world do they do it this way? Encourage everyone to suggest ideas for QI projects. If the front desk thinks there has to be a better way to deal with getting HIPAA consents, let them suggest a project and brainstorm the solutions. They have to do the work, and if they are more efficient, they have an extra moment to smile at the parent and notice that the sibling has an outstanding balance on their account. Everyone can win when the entire team has a continuous improvement mindset. This concludes the third and final in the three-part series on quality improvement. We're excited that you have come on this journey with us to understand what is needed to create a successful quality improvement program in your office. We hope you're ready to begin to plan what projects you might want to embark on and who you will need to be on your QI team. Thank you so much for your time and attention. It's been my pleasure to host this 3-part series on quality improvement for your practice. And at any time that I can help you embark upon the journey, please feel free to reach out to me.
Thank you, Iris. So I know we want to be respectful of folks' time, and so one of the things that we wanted to do is just wrap up here with a couple of announcements, and I can certainly stay on with our team, but I just wanted to thank everyone for hanging in there today. I know it's been a long webinar, but I hope that you found it useful. We wanted to just update you and remind you about our webinar dates that Iris sends out, so we have upcoming webinars, the dates there. We also have our conference dates, the next one coming up in October on transition. We hope all of you will be there. And probably most germane to this discussion today is our Quality Boot Camp, which is on November 29th in the Harrisburg area. So please be sure to follow up with Iris. She'll be sending things out. Be sure to RSVP. And I want to thank everyone on my team at Medical Home for making this happen, and thank all of you for all the work that you do in Medical Home every day for kids across Pennsylvania. I don't know if anyone had any questions or thoughts. I know people probably need to get back to work, but I'm happy to stay on for a few minutes. Don't forget the handouts that Iris graciously provided. Iris, if there's any instructions on the unmuting. I seem to mess that up all the time.
No, that's fine. So anyone that is on the phone that would like to ask a question or a comment, hit #6. And then anyone that would like to ask a question via the computer, the Q&A box is there. Well, Renee, I want to thank you on behalf of the team and the participants for taking the time to go over everything. You did an awesome job.
Thank you. My pleasure.
I still don't see any unmuted lines or questions, so I think this would be an okay time to let people go.
Great. Well, I hope everyone has a great weekend, and thank you, everyone, for your attention. And don't forget that the Quality Boot Camp is going to be just an even deeper dive to what we did today. We hope that you all continue to be with us and keep doing your awesome quality improvement. Thanks.
Thanks, Renee. Bye, everybody.